Thank you. First, it's my duty to thank the kidney warriors, especially Vasundhara as well as Marianne, for asking me to moderate this session and be here. It's a pleasure, and it's quite an important subject. You're looking at trying to prevent chronic kidney disease. Chronic kidney disease is on the rise and accounts for the accounting of chronic kidney disease for deaths has gone up from 15% in 2003 to 38% in 2013, and it's gone up even higher now. If you look at diabetes, 40 to 60% of patients who are in hospitals undergoing dialysis are diabetics. If you're looking at hypertension, about 80 to 90% of patients on dialysis have high blood pressure. So it's very important for us to try to prevent chronic kidney disease developing, and diabetes and hypertension are those two diseases that are paramount, that we try to control, prevent, reduce the complications therefore of kidney disease. Now the other thing I would like to say, hey, that's my phone. So I would just tell the GPs who are here that if you could do a GRBS and a urine dipsticks for every patient who comes to your clinic, that would be some sort of move towards prevention. Not just a patient, and I have started doing this in my clinic. I try to ask every relative or caregiver who accompanies the patient to get a GRBS and a urine dipsticks done. Just for the heck of it, you don't know who you're going to pick up. Now I have an August gathering of diabetologists and ophthalmologists here. So I'm going to start by asking Dr. Manohar, what sort of patients do you see in your clinic? How many of them are diabetics? Do they present early to you? Do you have a problem with a late diagnosis of diabetes itself, let alone CKD?
Yeah, thanks for the invite. I'm very, very happy to be associated with this Kidney Warrior Foundation. So in the COVID time, we had done some lifestyle related talks, and thanks for bringing me on here. Yeah, unfortunately, I say most of the time these diseases are silent diseases. It be diabetes, hypertension, even simple anemia most of the times, and the kidney diseases. So many times people will ask, if you have a pain, you come running to the doctor immediately. It may be very, very trivial, or a fever. People will come because it is bothering them immediately. So most of the times, 50+% of the diabetics are asymptomatics. So sometimes even when you check the sugars, as you rightly pointed out, don't look at just the patient, but also the family. When we look at a basic blood glucose or a blood pressure, I make it mandatory in my clinic for even the bystander also to be checked, as you rightly pointed out, and that is the first way to go about, is what I feel. So many times we see high readings and they say, no, it can't be. So denial is always the first response of human beings. So yeah, it is a silent diseases. People crib that even COVID, which was a relatively new disease, caused a lot of devastations, had a vaccine. I say, yeah, even for non-communicable disease like diabetes, hypertension, kidney disease, heart disease, there is a vaccine, and that is education and lifestyle modifications. We don't have to feel bad that there is no specific vaccine. There is a much broader vaccines. That's what I was very happy to know, that what Professor Mani did, like we need to prove to the world that that is a vaccine. What better vaccine than to have to checked and prevent it?
Thanks. I'm going to move to looking at ophthalmologists. How can they help prevent kidney disease? Can ophthalmologists help? So let's move to Dr. Santosh. Dr. Santosh, how do you screen diabetics, either type 1 or type 2, for eye disease? What eye problems do these patients have, and do you advise these patients to do anything else if you detect eye disease due to diabetes?
First of all, thank you all the organizers for giving me this opportunity. Sir, yes, every newly diagnosed diabetic is screened, like you said, with RBS, and also we do a routine blood pressure monitoring also. And whenever we do detect any signs of diabetic retinopathy, we do tell them to get a full physician checkup evaluation, including we actually ask for the lipid profile, serum creatinine, blood urea, and if anything turns up, we make sure they reach a nephrologist. Suppose anything turns up.
Can I add to that, sir, if that's all right?
Please, I was going to come to you next and ask what sort of tests would you do as a diabetologist to, look at other organ damage, and therefore we are looking at chronic kidney disease, and how do you go about, when would you start screening? So diabetic, either let's say a type 1 patient versus a type 2 diabetic patient reaches you, how would you screen this patient for kidney disease? When would you start screening? There are many patients who come to us saying that namdu bari sugar check ಮಾಡ್ತಾ ಇದ್ದಾರೆ, ಈಗ sugar, then they show us 2 to 3 years of sugar of PPBS, FBS. So we sometimes don't see creatinines or urines. What is your advice on that?
Yeah, thank you for the question, and thank you to Marian and everyone from Kidney Warriors Foundation for the invite. As a physician, as a diabetologist, my appeal to all of you treating any patients with diabetes is you need to practice comprehensive care. So we don't look at sugars alone anymore. A patient walks into my hospital, whether they've been diagnosed that day or they've been diagnosed 5 years ago, I really do not have the confidence that they've had comprehensive care unless it's someone who's seen a very well-known colleague like Dr. Manohar. Otherwise, the care is kind of fragmented. So if someone walks in to see you, what do you need to do? Check their A1C, get a renal function test, measure the UACR, get a lipid profile, check the thyroid function, check their eyes, check their blood pressure, check their feet, check their vascularity, get an ECG. And then if you have something vague, like breathlessness on exertion, unexplained fatigue, they possibly also have preserved ejection fraction and heart failure, and you might need a cardiologist to step in and do an echo. So this is really what a physician, a GP, and a diabetologist needs to do today. And all of this is certainly possible, and we have been doing it in our hospital for every single patient. Not all patients are happy about this. A lot of them complain, and some of them, once they hear the procedure given by the reception, they walk out. But we have never stayed away from the process because we believe that comprehensive care and screening from day one is the way to go. So we did a study nationwide in about maybe 2015-16 from several hospitals and looked at the data of patients with newly diagnosed diabetes, diagnosed with the diagnosis duration under 3 months. 1% had kidney disease, 6% had diabetic retinopathy, 90% had dyslipidemia, and 30% had hypertension. So you know where you stand. If this is the percentage with newly diagnosed people with diabetes, what happens after 5 years of diabetes or after 10 years of diabetes? The next appeal to all of you is checking a creatinine and a UACR is easy. Measure the GFR, please, when you give your medications to your patients. We can't look at a creatinine alone. It by itself doesn't mean anything. Check the GFR, because today we have so many diabetes therapies that prevent progression of kidney disease when used. We have SGLT2s, they've gone off patent, they help the kidney, they help the heart. And we have GLP-1 RAs, which are expensive. The third appeal is check your eyes. Now, doctors from Prabha Eye Clinic and we share a lot of patients in common. But in addition to patients who prefer to go back to them because they've been seeing them over a long time, we don't actually refer patients to an ophthalmologist. Okay, so we have a fundus camera in our hospital. You just take the fundus phone, the camera, and you take a photo. You don't need to dilate the eye. And the AI on the camera will give you a diagnosis of whether the patient has referable diabetic retinopathy and if the patient has glaucoma. both silent killers, which you can prevent. And if it's normal, take a photo again when they come back for their annual physical after 1 year. You diagnose, the AI tells you there is a problem, refer to the ophthalmologist. 50%, this is statistics worldwide, don't go to an ophthalmologist if they have to go to a different hospital. So while the focus is on kidney, we know that eye and kidney is related, we know that heart and kidney is related. So all of you really need to step up, and I'm sure many of you are, and we need to practice comprehensive care. So I think that's my answer.
Thank you.
So can I just add one bit?
I'm going to come to you, Dr. Dhwani.
Okay.
I was just going to ask you, picking up on what Dr. Bhavana said, and since the health commissioner is here, what about tele-ophthalmology for the masses? Is that something that can be done, especially in remote areas? Can the general practitioners here have something in their clinics, which I'm sure they can, and I'm sure some of them are already following it, have something in the clinics where you can take a photo of the eye and then look at diabetic retinopathy, initial screening at least. How do you envisage that as a plan, and how can we put that forward to the health commissioner here to do it on a much larger scale, not just in urban areas, but in rural areas where there will be an absolute lack of specialists. But if you can have some sort of a computer with a camera to pick up these things, why not? What is your, and whatever else you wanted to say.
Teleophthalmology is the way to go, because all our specialists would be concentrated in the urban areas, and the rural, there is a huge urban-rural divide. So teleophthalmology means that there is a technician, there is a van, there is a fundus photograph, probably a non-mydriatic. Non-mydriatic means we don't have to put drops to take the photographs. So this good quality photograph would run around in the rural areas. It's like a van, and it picks up photographs. It transfers all these photographs onto an app, and this app is logged on to in the house of the specialist in the city, where we can give comments, and these comments are transferred back into the computer, where the local doctors, the GPs, can look at the answers of whatever this patient has, yes or no, diabetic retinopathy, needs a referral, and they can convey to their patients. This program is very much running. Actually, we have our hospital, which is Vitala Hospital, which is doing this program, and it goes to various clinics in Karnataka. And there are over 10,000 patients who are already onto this program, and the photographs have been taken regularly. This van moves around for the whole month, going to different districts, different hospitals, picking up photographs, and the specialist sitting in the hospital will be giving their inputs for the same. So teleophthalmology is extremely important in terms of rural and outreach programs for outside the city population. And nowadays the cameras are of very good quality, which can pick up early diabetic retinopathy. And we have diabetic retinopathy which is divided into mild, moderate, severe, very severe, proliferative. So most of these diabetic retinopathies just need to be screened. Not all of them require treatment, not all of them are vision threatening. So the cameras do a good enough job to pick up diabetic retinopathy and will give you the timeline of screening. Any urgent referral will definitely have to be brought back to the city or to the nearest retina center. So as Madam mentioned, AI is also very accurate in terms of diabetic retinopathy. AI is there, it's getting developed further on with hundreds of images being fed into the machine, and its studying is happening. So AI for glaucoma, diabetic retinopathy, and we do even have retinopathy of prematurity where AI is coming in actually. And this does help in a way in a local practice actually, even in the cities where like how Dicon has fundus photographs. So if that is done and the patient does not have any problem, that is good enough for diagnosis. We do not have to actually go back to the doctor. It is around 80 to 90% sensitive to pick up things and can prevent eye disease. So vision threatening problems can be prevented.
So some ideas here for the health commissioner as well to look at as a screening for let's say kidney disease, eye disease in diabetics. So for example, in a NAMA clinic that is coming up in a big way, why not have a dipsticks for urine so that you can detect protein, a GRBS definitely because it's very handy to detect diabetes, a creatinine level in the blood that will tell us whether the kidney is abnormal, a fundal screening that will tell us something about the eye, and so on and so forth. All possible, and this is something that the general practitioners can adapt or adopt in your clinics as well. I'm actually going to stop asking questions and throw this open to the general practitioners who are available here in the audience, because I'd rather that they ask the questions, and if they have any thoughts that they want to share with us, and then I'll put that across to the panel here and see how they respond. Do we have any questions here from the audience, please? Yes, please. Please introduce yourself and ask the question.
Sure. Yeah, I'm Dr. Krishnaswamy. I'm a physician. It's very good that you pointed out simple dipstick of urine is very important, and I agree with you. And when do we say that it is significant? 1 plus or 2 plus? When do we, I mean that sometimes I get confused. Sometimes even if in other conditions like congestive heart failure or febrile patient, they can have 1 plus protein. So that gives a bit of confusion. Is it what? Is it sort of how serious? I mean, how mild it is, or how mildly moderate it is? That sort of confusion. How do we sort it out? 1 plus or 2 plus? There's a bit of confusion there.
Fair enough.
Yeah.
It's more a question for the nephrologist than to the panel, so I may as well answer it myself. The dipsticks is mainly a screening tool. Obviously, fevers can cause proteinuria, exercise can cause proteinuria, and these are physiologicals of proteinuria. On the other hand, 1 plus, 2 plus, they are not very quantitative measures because this is dipstick. So if there is proteinuria detected on a dipstick, you would then want to evaluate this patient further. You would want to do a simple urine protein creatinine ratio, which is very easy, costs about 150 to 200 rupees in most labs, and you can actually quantitate the amount of proteinuria there. The number that you get may mean that this patient has a gram, 2 grams or 3 grams of proteinuria. Unfortunately, the 1 plus or 2 plus may not correlate with, so a 1 plus may still have nephrotic range, a 4 plus proteinuria may still have just a gram of protein in the urine when you actually quantitate. The best quantitative measure is 24-hour urine collection. Seldom happens in our setup these days because it's cumbersome. It would be ideal, but it's cumbersome. So we've sort of gone for this urine protein creatinine ratio, which is a morning sample of urine to check both the creatinine and the protein in the urine, and that sort of gives us some sort of data on the actual amount of protein in the urine. Any questions from the panel for the audience? If not, I'm going to another question to the ophthalmologist, asking them about. Yeah, please introduce yourself, please. Your mic is coming. Hang on.
Regarding the diabetic screening, I would like to share my thoughts from the health department, what we had done. I retired as a director of health services in Karnataka 7 years back. About 6 to 7 years before that, we had funded from the government of Karnataka purchase of a fundus camera. Of course, it was a very bulky and cumbersome and all, and we had given it to Narayana Netralaya, which they were doing it. 2 3 years we continued with that. Then the time came through when they asked for a replacement of it, costing another 25-30 lakhs. That was the time the Vitala Institute of Ophthalmology, along with the Arvind Hospital, they procured one. All the things needed a big vehicle to go around, and it was a very cumbersome process. Later on, the last 4 or 5 years, I came across another one, which I can call it as a fundus camera, a smaller one, weighing about 1 or 1.2 kgs, from the Remedio Laboratories, Bangalore. And it has also been a proof of concept which has been done. We have used that in the Muddenhalli Satyasai Sarala Hospital, where we have about 9 to 10,000 diabetic patients under treatment. So now the thing is, it has come down very easier, and earlier we needed a big antenna, and the things it don't go. And over a decade that has changed a lot. But now the thing is, I think even the iPhone has got a fundus app which has come out for the taking of the non-mydriatic photographs and all. I think we should look into those issues.
Thank you, sir. It's actually the same camera I was talking about. It also now gives the diagnosis, the Remedio fundusophone camera, in addition to just giving the photo 7 years back. Now, since 3 years, it's CE approved, and it gives the diagnosis of referable diabetic retinopathy and referable glaucoma as well. So my appeal to the commissioner is to look into the Remedio eye camera for eye cams.
Yes. Can you give the mic, please?
I was retired additional director, project director RCH. I was a child health consultant during 10 and 11. We had provided RedCam costing about 1 crore at that time to Narayan Hrudayalaya, which was already signed by them in Government of India. They have placed the RedCam in Raichur, distributing about 6 northern districts. And they have done a wonderful job, and still they are doing it, sir.
Thank you. My question to Dr. Manohar, how do you envisage mass screening of patients, let's say diabetics, let's say non-diabetics? You don't know who are going to become diabetic in our population. We have the genetic tendency, we have the lack of exercise, the eating habits that make us the diabetic capital in the world. How do you envisage a mass screening program to look at how to pick up diabetes early in such a population?
Yeah, very important point. I think nowadays there is the in thing is reversal of diabetes. There are so many things going on in it. So I always ask, why not preventing diabetes in a much bigger way rather than thinking of reversal? Genetics, we always have been told that South Asians, especially Indians, are at very high risk. So we can't change our genes. We never complained when we inherited the properties from our patients. But when we are at a risk of developing diabetes, hypertension, heart disease, oh, we complain. My parents gave it to me. So genetics just load the gun and lifestyle pulls the trigger, as I always say that. So first thing is education. That's what I'm saying. Actually, after taking over as chairman of KRSSDA, we are planning to do something called as Madhumeha Pathshala or Vaidyakiya Pathshala. Every school we should approach, again with the help of the government, possibly to know your numbers. First is the kids should know what is their age, height, weight, what is their normal BP, what is the normal sugar, what is the normal cholesterol, is there an annual eye check, kidney check done. And they should go back and ask their parents. That is the homework, which I am planning to do that. They go back to their parents and when did you check, did you get it, and they have to get the marks on it. So that is what will drive. Because any camp, we even from KRSSDA, we adopted villages. It so happens we adopt, sometimes we are not very consistent. Even when you are consistent, people, the same group of people will come, check it. They are more looking towards getting the free drugs, which government has banned anyway about the free samples not to be issued for various reasons, and then they go back. So we don't actually really reach, and it is most often than not the camps are futile. Only the few who come, others may still have doubts on it. So I think the camp should be, the health parameters should be a school curriculum. And I also work for one company, Act FiberNet. I say, you give them so many other targets, why don't you give them health targets also? So now I am developing a docket where ex-Manohar employee of Act, his height, his weight, his ideal weight is this, his ideal BP is this, he's on these medications, annually he has to do this. So this is much more important than driving somewhere, some Sunday we all go and do some 500 patients, 1000 patients, sugar, BP checkup, and then we come back, everyone forgets about it later. So yeah, it's important, pertinent to get these checkups done. I think the Namma clinics or the PHC centers, we have collaborated with the PHC center because we go and come back what happens to the patient next after doing a camp of 500, 700 patients. So this collaboration, government collaboration, and I think empowering the students is more important than empowering their parents, which they will anyway forcefully get it done. And then raising awareness that all of these are silent diseases. We can't change our genes, but we can change our lifestyle.
Thanks, excellent idea, and that's something that we should sort of consider putting into practice. Again, I will ask anybody in the audience,
Yes,
if you want to ask a question, please go ahead.
I am Vivek from Fortune World Media. This is regarding the chronic kidney disease, what you were telling. What is the impact of the chronic kidney disease in Bangalore and Karnataka? How is it? How will you help the?
So, if you're looking at India as some statistics that you want, you have about 800 per million population within India who develop chronic kidney disease. End-stage renal failure, there are about 150 to 200 per million population that have end-stage kidney disease. Every year, more than 15,000 patients end up on dialysis. Of these patients, about 32% have insurance, 68% of these patients have to pay from their pocket, and more often than not, adequate dialysis cannot be done to those who pay from their pockets because they will skimp on dialysis. Therefore, the mortality rate is very high. In patients who start on dialysis or chronic kidney disease patients, about 38% of them will die within the first 2 years of starting dialysis. This means that chronic kidney disease patients have a worse mortality than some cancers. And this is very important to keep in our mind, and therefore prevention would be ideal. We'll ask another question for the ophthalmologist, and any one of you can take it, on what about fluorescein angiography? How important is that as opposed to an optic fundal examination? Is there a chance that we can detect early diabetic retinopathy with fluorescein angiography better than optic fundal examination?
Fundus fluorescein angiogram will definitely show up more things than we see on a clinical exam. So if I don't see any diabetic retinopathy on a clinical exam, on an angiogram, it will show up some mild, moderate retinopathy. But it's not really important to subject a patient just to detect diabetic retinopathy to a fluorescein angiogram. Because in the early stages, whatever is, even the ETDRS, which was a landmark study in diabetic retinopathy, it was not till the end stage or till severe diabetic retinopathy or diabetic macular edema that we need any kind of treatment. So in a mild or a moderate or even for a severe retinopathy, we do not have any treatment except for control of diabetes and probably a regular checkup. Even early proliferative diabetic retinopathy may not need an immediate PRP laser. So just for the diagnosis of diabetic retinopathy, angiogram is not recommended because we are exposing the patient to an additional risk, which is an invasive procedure. However safe it is, there will be 1 in 1,000 patient who may just faint, collapse. There can be certain deaths, there can be allergic reaction, anaphylaxis that can happen with an angiogram. So unless we are looking for something very specific, like we want to rule out a PDR, that is a proliferative diabetic retinopathy, or we are looking at vision as a motto, like whether we have macular ischemia, what are we going to do for the patient for vision, or is there any benefit in treating the patient with an anti-VEGF injection. These are the things that we would want, like an information from an angiogram. For the detection of diabetic retinopathy, either a good dilated fundus exam or a good quality photograph. Sometimes the patient may have cataract, so the photograph quality will not be good, and that will not be enough for the diagnosis on basis of a photograph. So an examination by a doctor would be good enough. In those where we have doubtful areas, I would reserve the angiogram for that.
Thanks. I was just going to ask Marianne.
Can I add a few
on
points
timings
to that?
Sorry, go on, please.
Yeah. So the diabetic retinopathy correlates with the grade of diabetic nephropathy according to a few articles. So whatever is the grade of diabetic nephropathy or kidney disease that you come across, it would be better if a retina specialist is available nearby to send them across. And one more thing, the fundus photo will be diabetic macular edema when it's in the early stages. That might require treatment. So a relatively inexpensive thing that can be invested in by the clinicians would be a simple Snellen's acuity chart in the clinic where they can check the visual acuity along with the fundus acuity. If it's low, they might need treatment for diabetic macular edema.
I have 5 minutes more, or probably 3 minutes now. If you have any questions in the audience, please do ask. If not, I'm going to ask the diabetologist, Dr. Bhavna here. What about, you do?
I think about this retinopathy, one thing which I notice in my practice is, we now use the word diabetic CKD. Earlier it was diabetic nephropathy. It's a very vague term, but if you look at the prognosis, if somebody has got proteinuria, diabetes, CKD, and if there is retinopathy, invariably we think it is diabetic nephropathy, where the prognosis is totally different. There, they'll reach end stage faster. But if they have got diabetic CKD with no diabetic retinopathy, I think they are better off. They land in dialysis later, vascular access problems are less. So that way it helps us to differentiate in diabetic CKD. So the ophthalmology is very important for me in my practice.
I agree, sir, because I get a lot of referrals from nephrologists saying that please look at the fundus for retinopathy. And when we say that it is no DR in the eye, then I think the diabetologist, the nephrologist will prefer whether you want to do a kidney biopsy or not kidney biopsy. Something that is how you take it. So we have seen, at least in our urban center, tertiary practices, almost lots of general practitioners, lots of nephrologists, patients are aware. There's a lot of education that is going on, and they come in for this slip. There's a small slip, but then they come in for looking at retinopathy. So that's a good thing that is happening.
Also, I get more reference from ophthalmologists for diabetic CKD than my other physicians, other colleagues.
That is true, sir.
Go and meet nephrologists. I get good practice from.
We do diagnose diabetes from the eye also, or there'll be so many times that they would have not got investigations done. We would give a battery of tests, like at least the basic ones, look at it, and then send a referral letter that please go and see yourself.
So, Dr. Bhavna, a last question to you, if there's no more questions from the audience.
Yes, I have a question also.
My question is to the eye specialist. Please excuse me if my question appears silly. My confusion is, how do you manage to detect diabetic retinopathy in the case of cataract?
Not silly, that's a good question.
So that depends on the grade of the cataract.
Can we have the mic, please? This.
Yeah, that's what. Sir. So that depends on the grade of cataract. So when it's a very severe and hard cataract, we might also not be able to pick up any changes unless it has progressed into a proliferative diabetic retinopathy and a tractional retinal detachment that we can image on a B scan. Otherwise, if that stage has not yet been reached, we will not be able to pick that up. But we can pick up retinopathy changes, at least grossly, up till a stage where a glow from the fundus can be seen in an indirect ophthalmoscope. So we can still pick it up until very severe stage has not yet reached with respect to the cataract.
Sumir?
Yes, my name is Sumir. I'm from Kidney Warrior Foundation. I'm a two-term transplant recipient. I have a question to the diabetologist. Because recently I'm taking part in the transplant games, so I had a camp in Delhi. I had a very interesting chap who was a transplant recipient. He claimed during a nutritional discussion that he's taking alkaline water and his numbers from 14.2 had come almost normal to almost 6.3. And second thing, he said that he's off medications. And he's also won gold medal in the last transplant games from badminton. So he had asked this question to the nutritionist also. So we all had this doubts, how far it is possible just taking alkaline water, and he swears by it, that, that his numbers have come to almost normal and he's off medication.
Highly unlikely, I'd say, but I'd request Dr. Bhavana to answer that.
Yeah, so thank you for the question. And we often get a lot of questions like this about different things we consume. But there is no hard scientific data on the use of alkaline water for remission of diabetes and going off medication. There is science behind diabetes remission. Please note, I'm not using the word reversal. There is no reversal for diabetes, it's a remission. And there is very good data and science from Roy Taylor in the UK on that. But that is mostly by weight loss, and weight loss of not 1 and 2 kgs, it's weight loss of more than 15 kgs, which is basically following a 600 calorie, largely liquid diet. So it's not the food you and I eat, it's like a protein drink or a meal replacement drink, which is 600 calories. You do it for 12 weeks, and still 50% can go off their diabetes medication, provided the diabetes was detected in the last few years. Longer the duration of diabetes, this is not going to work. And the other 50%, this doesn't work, and that we attribute to genes, just higher amount of pancreatic fat, insulin resistance, or hepatic fat. So it can work in some people, but that's 15 kgs weight loss. There is no data that I've come across on alkaline water. Dr. Manohar, have you? But we hear a lot of things from patients, and we often tell them, look, you want to try something unscientific, and if there's a side effect, then we have to deal with that, so keep that in mind as well.
I'm a bit liberal with the patients. There are a lot of pathis, allopathy, homeopathy, Ayurveda. Which pathy he has to choose is his prerogative. Yeah. Second thing is always, I don't know, I hope he has done his creatinine. Secondly, I think, yeah, reversal remission, even though people talk about reversal remission, is a bit of a technical word. So it may not gel with the audience. That's why they talk it on reversal and other
like
things.
Cancer, you're never really going to, live away without cancer. It may come back. So diabetes is like that. You can be off medicine, but it may come back.
I have something to add here. Sorry to interrupt. Actually, the moment you said this question was posed to the nutritionist last time, basically I think in the last few nutrition symposiums, even the national symposium, we've been asked this question very often about how this alkaline water, this topic of alkaline water is being pretty pushed upon. There's heavy marketing, there's a lot of, focus now on this alkaline water. So this topic had been taken up in the previous nutrition symposiums, and we as clinical nutritionists have scored a lot of data, and as Dr. Bhavna said, there's no hardcore evidence to say that alkaline water helps in any way. In fact, there is a little bit of data that shows in the rural areas, pediatric patients were affected in a negative way by consuming alkaline water. So I think we have to take this with a pinch of salt, basically, when it comes to, as you said, the alternate therapies.
Thank you.
Let's be neutral on it then.
Thank you. Because that gentleman had invested around 3 lakhs on using the alkaline water machine, and he got it imported from Japan.
May have helped if he had some stone disease, I guess. Anyway, we're going to sort of stop the discussion here, and I'm going to thank the august panel of participants for giving their thoughts. The final takeaway, I'd say, to most GPs here is think about doing a GRBS for every patient who comes to a clinic, for every relative who accompanies the patient. Consider doing a dipstick screen for every diabetic, every hypertensive patient that comes to your clinic, and also make sure that if you have an at-risk a person, a relative accompanying that patient, at risk meaning a relative, history of hypertension, connections with kidney disease in the past. Think of doing a sugar level as well as a dipsticks for these patients. With respect to sugar control, I'm sure you people know what to do already. With respect to eye screening for diabetic retinopathy, please consider various tele-ophthalmology techniques, to be sort of something that you can have in your own clinics to try to screen these patients. And also, please consider reference to a nephrologist whenever you find the slightest doubt on the urine or the serum creatinine values. I thank Kidney Warriors again for giving me this opportunity, and I thank all the panel for being involved in such an active discussion. Thank you.